Last time I gave this presentation, a year or two ago, and we had no new drugs in 45 years in acute myeloid leukemia. So all of you had to listen to all of the extensive research that was being done to understand the natural history and biology of the disease. But now, this research is finally being paid off because now there are drugs that are approved for specific subsets of acute myeloid leukemia. So now it's even more important to know what kind of acute leukemia you have, because there are drugs that are specifically indicated for various subsets of acute leukemia. When we talk about acute leukemia, when I get a phone call from a friend or a colleague and say, hey, my aunt has acute myeloid leukemia, what is the best treatment? It's not possible to give any kind of meaningful answer. I need to know what kind of age the patient has, what age the patient is, what other medical problem patient has, and more importantly, what kind of acute leukemia does patient have? Is it a secondary disease? Is it acute myeloid leukemia that evolved from the prior bone marrow disorders? I need to know the exact cytogenetic and molecular signature of the disease to be able to, one, prognosticate this disease, just to explain how this disease is likely to behave, but more importantly, to come up with the best possible treatment. So in general, acute myeloid leukemia, just like most other bone cancers, bone marrow cancers that you've heard about today, it's accumulation of abnormal cells in the bone marrow, right? So normally, there are maturation process happening in the bone marrow. I'll show you some pictures. If you look at the healthy normal bone marrow, you'll see all kinds of cells in there doing all kinds of interesting things. In acute myeloid leukemia, this process of maturation gets aborted. So it stops at a certain point. So they do not mature, they do not differentiate, they don't become all those normal cells that we need to function, to fight the infection, to carry hemoglobin, to give you oxygen to your body. They prevent you from, they make your blood thin and not able to clot, and people have tendency of bleeding, among many other problems. So those differentiation stops, and you have an accumulation of identical, ugly-looking, dysfunctional cells, and that's what leukemia is. So the most problems that patients have, the way patients feel and what they suffer from are the consequences of this bone marrow failure. Again, the most important thing that I can tell you today that one acute leukemia is not another acute leukemia. So when I have a 25-year-old patient who has a low white count and translocation between chromosome 50 and 17, this patient going to have an entirely different treatment, entirely different outcome than, let's say, the same 25-year-old patient who comes in with a swollen gums, white count of 200,000 and has a FLT3 mutation. Not even, I know they're called leukemias, but they're completely different diseases. So this is kind of a simplified version of how differentiation and development of the blood cells occurs. So you have a stem cells, then differentiate into the myeloid and lymphoid cells. Myeloid cells further differentiate into the various neutrophils, monocytes, etc., as well as platelets and red cells. This is a simplified version, as you might imagine, but this is not incorrect. Just because it's simple doesn't make it wrong. And this is a picture of the bone marrow of the patient who has acute leukemia. As you could see, it looks very monotonous. That's the terms that we use. That bone marrow looks very much the same. And if you look at the cells, they're large. They have a very large nucleus with abnormal chromatin, multiple nucleoli. So this is what leukemia looks. That's how we know that this is what the likely diagnosis is. This slide, unfortunately, is to remind us that acute myeloid leukemia remains a deadly disease. So this is the data for 2017. The data is very similar for 2018. So it was estimated that over 21,000 patients diagnosed with acute leukemia in 2017. 19,000 in 2018, and about over 10,000 patients died from the disease. That year. So it's still no matter how many advances we have, this still remains a very significant problem. So age, as I told you, when the friend calls me with his aunt, I want to know what age the patient is, because the age, despite all the new molecular stuff that we have available to characterize the disease, age still remains one of the major prognostic factors of outcome. The older you are, the worse you're likely to do. So when a new acute leukemic comes in, a lot of things need to happen very, very rapidly. We obviously need to understand take a very detailed history. We need to understand, did a patient had a prior bone marrow disorder? Did the patient had another cancer and likely received radiation and chemotherapy, which have led to the development of this current leukemia? We do extensive blood work to understand, make sure they don't have any other infections, make sure that the organ functions are intact. Some patients present with a very high white count, which by itself could be a life-threatening situation. So we need to take care of that and make sure that patients do well and they don't destroy their kidney, because that obviously would not be very good for them and would preclude any kind of meaningful therapy if they do. We do a bone marrow biopsy and do very many tests on that bone marrow biopsy. Cytogenetics, molecular studies. And it's interesting, you know, that the things that we used to do at the beginning versus what we used to do at the time of relapse. Now we want everything before we start treatment. So before, you know, when I sit down with my patient, I say, you know, we're going to start this treatment. I know you have acute myeloid leukemia. I know you don't have this one subset of acute myeloid leukemia because that's treated differently. But all the other subsets are treated the same way. We're going to start chemo, you know, and 3 weeks from now, I'll tell you what your cytogenetics is, and that will tell us whether we would consider stem cell transplant or continue with the chemotherapy. Now I need to know all that information now, right before I start. Sometimes you can't wait, and sometimes patient is very sick and you need to start something, so you make the best educated guess with information that you have. But ideally, you would like to get all the cytogenetics, all of the molecular stuff beforehand, because there are a lot of FDA-approved drugs for each subset of the disease, but also, as you might imagine, there are innumerable clinical trials going on trying to push that progress forward, trying to take those 9 drugs that already have an FDA approval and find a new way of giving them to patients and giving to them early. At least at Northwestern, where I work, the assessment for the stem cell transplantation begins on the same day of the diagnosis. We may or may not decide to proceed with the stem cell transplant down the line, depending on patient's wishes, patient's disease, many other factors. But because the preparation for the transplant takes a long time, that preparation begins on the day of the diagnosis. As you might imagine, just because you get diagnosed with leukemia, life does not stop. So a lot of patients have a lot of issues, you know, psychological issue, financial issues. So we have a team of people who are helping to take care of that component of life as well. For young patients, although again, acute myeloid leukemia disease of older adults, the median age of diagnosis is 68. Being at a tertiary academic center, of course, we have people in their 20s and teens, and, you know, so fertility preservation is a very important component because hopefully we'll cure the patients, and I want them to go on and have a normal life, including having children. And of course, the consideration for a clinical trial. So how do we separate the disease? For years, we've been talking about French, American, British classification of the acute myeloid leukemia, which effectively look on how an attractive cell appears, and that's what we based our characteristics or classification on. I think it has been 3 or 4 or 5 years since the last patient asked me, what is my FAB classification? Not even patients ask about this stuff anymore, because that classification have been replaced by classifications that incorporates, as I said, cytogenetic and molecular abnormalities to define the subset of the disease. And just to give you an idea how things were evolving. So prior to 1980s, the things that we used to understand and classify the disease were age, which is still very important, performance status, meaning how well patient is feeling and what other medical problems they have. Again, we're still using this. White blood count and presentation, prior bone marrow disorder, right? We knew that those people don't do well. Not that we can do anything about it because we didn't have any other treatment. We just knew they're not going to do well. So, but that's still an important component because now we have an FDA-approved drug specifically for patients who developed acute leukemia that arise on a background of prior bone marrow disorder. In 80s and 90s, we discovered the chromosomal abnormalities play an important role in the behavior of the disease, and based on those, we separate patients in the favorable, intermediate, and unfavorable risk. Again, mostly for deciding who we should give a stem cell transplant to, and predict how the disease is going to behave, because we did not have many treatments available for those patients. In the 90s and early 2010, we started to look at the molecular abnormalities like FLT3 mutation, MLL rearrangement, NPM1, CBP alpha double mute, c-KIT, IDH1 and 2. And again, for years, those things remain just a prognostic markers of the disease. Now they're targets. Now they're drugs for IDH1 positive acute myeloid leukemia, IDH2 positive acute myeloid leukemia, several drugs for FLT3 positive acute myeloid leukemia, different FLT3 mutations, and many, many coming. And now we're using next generation sequencing to try to define the personality of the acute myeloid leukemia. So this is how we used to risk stratify the patient based on their chromosomes into favorable, intermediate, and unfavorable risk. And just to show you that this was not just an academic exercise, this is Kaplan-Meier curves of incidence of relapse and overall survival. And you could see that patients with favorable risk disease have a meaningful chance of being cured with just chemotherapy alone, in the range of 60 to 80% actually do well, while patients with adverse risk cytogenetics do poorly and effectively guarantee to relapse. As you can see, the top red curve on the first graph, effectively guarantee of relapse. So nobody gets cured with the chemotherapy alone. We further were able to identify patients who do have abnormal chromosomes into those who have a monosomal karyotype. Monosomal karyotype is specifically defined as abnormality of chromosome 5 and 7 with some other structural chromosomal abnormality. As you could see, the survival of those people is pretty much non-existent. Before, I just used to know about how the patient's going to do. Now, I have a treatment specifically for that patient population. So it's very, very important to know what kind of disease they have. Well, this is just to give you a taste of how many other molecular abnormalities are present and important to consider. And this list is only about to grow. If we just look at the patients who have an intermediate risk cytogenetics, and we look at the specific molecular signature, we could see even the people with intermediate risk disease, we can break them in very different groups in terms of survival based on the presence of the molecular abnormalities that they have. And again, I'm specifically not delving in because I know you are here not for intellectual stimulation. You are here because of your loved one has a disease and you want to understand the disease better. So I think it would be more productive if you ask me a specific question about the specific disease. So instead of me telling you all the possible molecular signatures that exist. And this is just the most current NCCN-based risk stratification based on the cytogenetic and molecular abnormalities. And this is to say it's not just which molecular abnormality is present, but what company it has. So it's the family of several molecular abnormalities, not just one molecular abnormalities by itself that define the prognosis and behavior of the disease. This beautiful curve just shows you, let me see if I can I work with this channel? So the width here tells you how common the mutation occurs in acute myeloid leukemia, and the width of this band tells you how common this mutation like to occur with another mutation. So there's some mutations could never occur together, and some like to be present together. Why is it important? Well, if I have the drug for mutation A, and I have a drug for mutation B, and if I know that the patient frequently have both those mutations in one disease, it makes perfect sense to combine the two drugs together to see if I can get a better result. So that's why it is so important. So those are molecular mutations that we've been talking about for a very long time, and now again we have the drugs that are FDA approved or on clinical trial very close to be approved for a specific molecular abnormality. So FLT3 mutation and FLT3, the different FLT3 mutations known to be associated with the high-risk disease, explosive disease that also goes into remission, always tend to come back, and everyone likes to relapse after the stem cell transplantation. Now we have multiple drugs that are FDA approved for various FLT3 mutations, and there are multiple drugs are very close in phase 3 clinical trials. Hopefully we'll get approval. So we begin to use these drugs in induction, consolidation, and also as maintenance after the stem cell transplant, doing everything we can to prevent leukemia from coming back. IDH1 and IDH2 mutation, we have drugs, both drugs available for IDH1 and IDH2 mutation, and there's many other drugs specifically for IDH1 mutation in the pipeline. c-KIT mutation typically associated with a bad prognosis. We do not have an FDA-approved drug. However, there is drug for different form of leukemia that targets c-KIT, and there is data enough for most of us to add this drug to standard regimen if the patient has a c-KIT mutation. TP53 is an evil mutation. It's evil in CLL, it's evil in myeloma, it's evil in acute leukemia, and those people tend not to respond to chemotherapy. Now there are drugs that are trying to reactivate TP53 mutation, which hopefully will allow for those patients to respond to therapy appropriately. This is the graphs that I've been referring to at the beginning, and Dr. Steve mentioned. So for 45 years, we had induction chemotherapy, 7+3, and it's all we've been using. And again, not for a lack of trying, right? We added drugs, we combined them, nothing led to improve overall survival. And since 2017, we have 5 drugs that are FDA approved for treating various subsets of acute myeloid leukemia. And again, I have like little slides for the drugs because it's supposed to be update. So for drugs that have been FDA approved in 2018 and 19, but again, I'm happy to discuss whichever drug you guys like in as much detail as you're willing to hear. So in terms of therapy and approach for acute myeloid leukemia, again, everything is different. It depends. For some patients, they can die as they're moving from the emergency room to the floor, depending on what kind of leukemias they have. Some people, I can let them be at home for a couple of weeks until I get all the information that I need to devise an optimal treatment strategy. I'm anxious when they're not in the hospital, but I know they're going to do okay. They can wait until I get all the information. So what is the treatment paradigm? Well, it's typically is we like to get people into remission, and then we would like to see if we can convert that remission into the cure, right? That's an optimal situation and return people back to their normal life. And that have been the paradigm with chemotherapy, right? You give somebody chemo, they either respond to therapy and then they have a shot at something long-term, or they don't, and we're all in trouble. Now with the new drugs that we have with FLT3 inhibitor, IDH inhibitor, the paradigm has shifted, and I mean, we were involved in all the phase 1 clinical trials, so we're the first people, our patients were the first patient to receive many medications that's now FDA approved, and you realize that that paradigm is changing. So the patient's taking a pill, he still has acute leukemia in the bone marrow, yet he does not require transfusions, he's feeling pretty darn good, he's not in a hospital, and you begin to kind of revamp your whole view of acute leukemia as becoming a chronic disease. And yes, for a period of time, those drugs eventually stop working. They're not curative. But for a period of time, and for some people it's 2 years, that life is actually normal. They just have to take a pill, just like people take pill for hypertension or diabetes. So this is very rapidly changing world in acute leukemia. Depth of the remission is very important. As our technology has improved to measure the amount of the disease, so something that's called MRD, we used to call it minimal residual disease, now we call it measurable residual disease. So that's also an important, so when you discuss your remission with your doctor, it's important to know what tests were used to determine whether there is leukemia or not, right? Was it just morphological evaluation by a pathologist looking at the slide? That is important. What about cytogenetic? What about molecular? What about other tests that could look deeply into the bone marrow and determine if there are any leukemia are present? So for patients who are fit, and I specifically do not say younger patients because there are plenty of older patients who are very fit, who do not have major comorbidities, and they're interested in the curative approach. So again, you do something to get them into remission, and then you either give additional treatment like consolidation or stem cell transplant. And nowadays, for patients with very high-risk disease, as I already mentioned, we do post-transplant maintenance to prevent the disease from coming back. For patients who are either not interested in high-intensity chemotherapy or unable to tolerate intensive chemotherapy, again, achieving a remission is still very important, because if you get into a good remission, at least for a period of time, people can have a chance at normal life. And again, the important criteria becomes getting people transfusion independent, making sure that they're at home, that they're not getting sick all the time, and don't have to run to the hospital every 15 seconds. So that's also an important consideration in therapy. And again, despite the 9 new medications that's FDA approved for acute myeloid leukemia, we're still actively involved in clinical trials because we are far from curing everyone, and our therapies are far from being completely safe. So until we accomplish that, they're always going to be a clinical trial. This is just a graph to show you that patients who have minimal residual disease behave as badly as patients who have acute myeloid leukemia, active acute myeloid leukemia, visible acute myeloid leukemia. So it's very important when you think you're in remission to know that the most sophisticated tests were used to define that remission. So do you guys want me to run quickly through the 5 drugs that have received an FDA approval for acute myeloid leukemia? Yes, no, don't care? Okay, let's do quickly. So ivosidenib, it's the IDH1 inhibitor. So in summer of 2018, it received an FDA approval for patients with relapsed and refractory acute myeloid leukemia that has an IDH1 mutation. It was a relatively small study, 174 patients. The rate of complete remission as well as complete remission with incomplete count recovery was 33%. Right, but you have to remember what patient population it was. The patients who failed everything, some of them had a stem cell transplant and failed. So, you know, that was a pretty amazing response for a pill. Median time to response was 2 months, so pretty quickly. Patients respond, the duration of the response was 8.2 months, right? So however amazing those responses were, nobody was cured of their disease. I have a number of patients on that clinical trial, and I took those patients to a stem cell transplant after they achieved remission, so those people are doing well. In addition to rate of complete remission, the transfusion independence was an important endpoint on the study, and 37% of patients who were transfusion dependent achieved transfusion independence. The drug was pretty well tolerated, you know, considering chemo and everything. We had to worry about differentiation syndrome, and again, I'm happy to discuss it with those people for whom it's, you know, makes sense, who wants to know. But in general, there are some gastrointestinal issues, some joint aches, but overall, the drug was very well tolerated. Several days ago, this drug received an FDA approval for the frontline indications. Again, those of us who've been involved in a phase 1 clinical trial have been giving it to patients. For older patients who do not want chemotherapy, we've already been giving it this drug, but now it's formally FDA approved for untreated patients who unwilling or unable to receive intensive chemotherapy. The rate of complete remission was incomplete count recovery is 43%, 41% transfusion independence. So as you might imagine, there is like 5 million combination clinical trials trying to combine that pill with other medications to improve the rate of remissions, to improve the duration of the response, etc. So Glasdegib has been approved at 100 milligram dose. It has been approved in combination with low-dose cytarabine for older patients not fit for intensive chemotherapy. It was specifically aimed at patients who really cannot take chemotherapy, who has heart dysfunction, kidney dysfunction, and suboptimal performance status. Median overall response was 8.3 months, which was double of what it is with cytarabine alone, so clearly not a home run. I don't know, probably not a very popular drug, but again, for some patients, it is represent an option. Venetoclax, you just heard about venetoclax from Dr. Venugopal talking about chronic lymphocytic leukemia and lymphoma. So BCL2 pathway is important for development very important for acute myeloid leukemia. And so in November 2018, venetoclax in combination with either Vidaza, Dacogen, or low-dose cytarabine have been approved for older adults with acute myeloid leukemia, frontline therapy. There are several phase 2 trials, and rate of complete remissions were in the realm of 60%. So which is not bad considering the patient population and nature of the disease. So that's pretty much venetoclax, Vidaza, venetoclax, Dacogen at this point probably became the main kind of go-to therapy for most patients with acute myeloid leukemia. Gilteritinib, we used to call it a magic drug because I was joking that they put cocaine in this medication because all the patients suddenly felt really good on that medication, which in the world of leukemia, this is unheard of. Yeah, so we have experience with this drug for many, many years, and finally it's received an FDA approval in 2018. Again, single agent in an awful disease, 21% rate of complete remissions, which is incredible. And of course, now the drug is, we're trying to give drug as a maintenance. We try and combine it with the chemotherapy, with hypomethylating agents. So multiple clinical trials are ongoing. It's an oral medication. I refuse to pronounce the name of this drug. I used to know it as SL401. Treated patients also with it years ago. So there is a condition called blastic plasmacytoid dendritic cell neoplasm. For probably 2 decades, we did not know how to classify that disease. It was under lymphoma, but in the recent years, it has been under the leukemia classification. It's a terrible disease. It has a skin involvement and bone marrow involvement. Very, very aggressive course. Most people, unless you transplant them, most people die from their disease. So they tend to express a marker, 123 marker on those leukemia cells. And this drug, SL401, is a targeted therapy for patients with this unusual subset of acute leukemia. As you could see, it's a very rare disease. So in the first cohort, there were like 13 patients, right? It's not like breast cancer. When you have thousands of patients on the study, we got 13 patients. But we got complete remission rate of 54%, which is pretty remarkable. The drug is not toxicity free. There is a vascular leak syndrome that is associated with this. So that needs to be given in the centers that experienced in dealing with the toxicity. And I think this is it for the novel medications. All right. Again, I'm happy to answer questions and delve into details as deeply as somebody cares.